Hello, welcome to my channel Prime 32 Dental Lessons. In the last video, we discussed about curettage and its types. Curettage procedures are basic, ENAP, ultrasonic, and caustic. ENAP wasn't covered in last video, so here I am back to complete our curettage video. ENAP, this technique was developed and used by US Navy Dental Corps. It is a definitive subgingival curettage which is performed by BP knife and blade number 15. Aim is to cut the inner portion of the soft tissue wall or lateral wall of gingiva which is inflamed. That's why its name is Excisional new attachment procedure. To perform this procedure we use BP knife or blade number 15. So after cutting we get a clean and healthy gingiva. So no scraping done, and excision is done towards the root surface. Indications and contraindications. In indications, suprabony pockets in the presence of convex root surface, adequate keratinized tissue should be must, and it should be aesthetically pleasant. In contraindications, we see in soft tissue and hard tissue. Soft tissue, if there is hyperplastic tissue and inadequate keratinized gingiva. In hard tissue, if there is furcation, we don't do ENAP, then the flap surgery is done. And if there is osseous defect, Malpos teeth, closed root approximation, developmental tooth defect, and if the probing depth is more than 3 mm. If the procedure is done in more than 3 mm, then gingiva will contract and worsens post-operative healing, and it will be aesthetically unpleasant. There are advantages and disadvantages of ENAP. So after cutting of inflamed part, there is removal of epithelium, pocket lining, junctional attachment, and adjacent granulation tissue. So after cutting of inflamed part, we get improvised visualization and better access to root vision. So next is MGT, which is minimal gingival trauma. There is no trauma to gingiva and minimal trauma to post-operative recessions. Doesn't affect the bone. And next is facilitates new attachment, which is our main goal to be attained in this procedure. There is disadvantage of ENAP also, that is limited application. Only do it in supragingival pocket, can't be done in deep or irregular pockets. Next is armamentarium, diagnostic set, PMT, pocket marker, periodontal probe, periodontal curette, ultrasonic scaler, needle holder, manual scaler, surgical blade, suture, saline, cotton, anesthesia, syringe, periodontal copac. Next is procedure. 1 week before SRP is done, which is must for surgery. On the day of surgery, anesthesia is given. Few drops of solution is injected in lateral wall of pocket. It will help in reducing the bleeding and makes the tissue firm to be excised. Then mark with the pocket marker from placing it inside the sulcus as shown in diagram. Then with the help of BP blade or knife, internal bevel incision is made. Incision is made from the margin of the free gingiva apically to the point below the bottom of the pocket. This horizontal incision is given buccally and lingually around the tooth. The intention is to cut the inflamed connective tissue wall around the tooth and take out the damaged and detached part. After removing the soft tissue with curette, scaling and root planing of exposed cementum is done. Preserve the connective tissue attachment to the root surface. Pocket wall is flushed with the normal saline. Approximate the wound edges. If they don't meet, apply some finger pressure and interdental sutures are given. Then periodontal pack is given. Junctional epithelium forms in 7 days. Thank you. Please like, share and comment on this video to tell me what video you want next. Also, please subscribe to my channel Prime 32 Dental Lessons.